Good evening. It's now 6 o'clock, and I'm going to hand over to Dr. Petru Wessels from the South African National Blood Service, and she's going to take us through her presentation. Thank you, Dr. Wessels.
Thank you so much. Let me just start sharing my screen. There we go. If you can just confirm that you're seeing the right view.
We can see it. Thank you.
Perfect. So I think first of all, I really need to thank SAMA for including the blood services in their academic program and acknowledging the important part that transfusion medicine plays in patient safety. So without wasting any time, let's get started. This is not your typical ethics legal talk because that kind of never changes. The law stays the law, the ethical principle stays the ethical principles. What have changed is the way we apply that. Now, I'm a firm believer in informed choice, and it's been a long day for many of us, so I always start with the summary of my talk for those who feel they need to leave early. And if you haven't got a clue what you're looking at on the screen, we're talking today about the law, ethics, patient blood management, and optimizing patient outcomes. So you're sitting in an ethics legal talk and you're looking at a diaper-wearing devil and the fairy godmother from Cinderella. So clearly things have changed in our world in medicine. And the question is, what has changed? And it's all about the right choices in the current circumstances. So as trends in the medical field change, the trust relationship between the doctor and the patient also changes. And therefore, the right choice of conduct 10 years ago is not really the right choice of conduct today if you have to consider all the circumstances of the current time. Transfusion ethics can no longer be seen in isolation as an isolated topic related only to transfusion of blood products, treating adverse reactions, etc., etc. We now are faced with a duty bigger than just the patient sitting in front of us. And our actions and our thinking should not only be targeted at preventing transfusions, but very much towards the broader public's interest and achieving full health potential for all of our patients. And that speaks to the principle of health equity. So PBM principles are not new. I mean, it's widely published for the past 40 years in certain countries in the world. And I think it's time that it should form part of our basic thinking when it comes to patient evaluation, interaction, and our treatment plans, definitely. A lot of the headaches are ours. If I say ours, you are aware that SANBS delivers a blood service to 8 provinces, and Western Cape Blood Service delivers a blood service to Western Cape. So the ours is us and Western Cape Blood Service. So I'm not going to bore you with our headaches and our grey hairs. I'm going to concentrate on that what speaks to you as the doctor or the healthcare worker using the product. Let's start with ethics. I like to start with ethics. And Koski said, ethics is the branch of knowledge or philosophy that deals with moral principles. So the responsibility of the treating doctor is more than just deciding what is the appropriate treatment, what is the appropriate intervention. We also have the obligation to be of benefit to the patient, to minimize harm, and to respect the values and the preferences of our patients. The 4 principles of bioethics is autonomy, beneficence, non-maleficence, and justice. We grew up with this since the days that we were medical students. It's not new. Those of us that is a bit longer in the tooth know we'll find situations where the one is in conflict with the other, and that which weighs the heaviest given the specific set of circumstances should be considered. But all your transfusion-related decisions should be based on these 4 ethical principles. So looking at autonomy, the capacity of a rational, competent individual to make an informed, uncoerced decision. So first of all, you're looking at a rational, competent individual. The individual must get information and the decision must be completely voluntary. The competent adult have the right to choose what will and what will not be done to their bodies, And in the world of transfusion, it means everything around informed consent, but very much also around informed refusal. So as far as informed consent goes, there are specific requirements. The individual must be competent to understand what you're telling them, and they must comprehend the disclosure or the information. They must receive full disclosure, and the information that you give your patient must enable them to make a decision. Of course, the patient must consent to the proposed intervention or treatment, and the process must be documented. Looking at informed refusal, you need to respect the values and beliefs of patients when they are being met with refusal. Again, it must be documented. Please ensure confidentiality. We often become aware in the blood services of healthcare workers telling us the patient refused the transfusion, but later the evening they requested to speak to the doctor after all the family went home and the ward was cleared of visitors, and they then said, please do my transfusion during the night, that my family or friends is not aware. So we must ensure confidentiality for our patients. Previously autonomous persons that are presently incompetent, we must respect their previously expressed preferences to be treated or not to be treated. Beneficence. It's our duty as healthcare workers to act to the benefit of our patient, promote patient welfare, and we must keep in mind that beneficent actions can help to prevent harm to our patient, or it can remove conditions that may cause harm to our patients. So in the world of transfusion, it means the following. The transfusion must be based on a genuine clinical need, and if post-transfusion information becomes available of possible, potential, or probable harm, the patient must be informed. And one of the big good examples here is the Look Back program, where if a subsequent donation of a donor tests positive for a viral marker, we will inform the treating doctor that your patient was exposed to a potential window period donation, and then that patient must be traced, tested, and the process will follow through. Information concerning the transfusion received must at all times remain confidential. So files lying around in wards where the family and friends can quickly take a photo and then go home and Google and see that the patient received a transfusion while it might be frowned upon in their social environment, please prevent that from happening. Do not limit your patient's options. If you don't have a working knowledge of basic patient blood management principles, you are in fact limiting your patient's options. Non-maleficence speaks to the fact that I must do no unnecessary or unreasonable harm to my patient. I must not expose my patient to an unnecessary risk. I must not deprive others from the goods of life. So here it comes in that whole concept of it's bigger than just the patient sitting in front of us when we're working with the scarce resources. In transfusion, we are back to the fact that a transfusion must be based on a genuine clinical need. You have to weigh the benefit and the risk, and you have to choose the best course of action for the patient. You must avoid unnecessary transfusions or unnecessary products because transfusion risk is not related to the transfusion episode. A transfusion risk is related to each individual product. So every unnecessary product is exposure to an unnecessary risk. If you have inadequate knowledge of the treatment that you are exposing your patient to, that is considered putting your patient at unreasonable harm. The standard of care. If you walk through your hospital and you are seeing blood products lying on bedside tables waiting to be transfused, whether it's your patient or not, it's your duty to speak up because that speaks to the fact that it's not best standard of care that's being practiced in that environment, and it can harm other patients. We are talking about uncross-matched emergency fridge blood use. Now, if you look in South Africa, and we have got the benefit of seeing the stats for 8 provinces, so it's really a beautiful place to be sitting in, you often see the reasons why emergency fridge blood is being used. And emergency fridge blood has not been cross-matched for your patient. Therefore, the level of risk that you expose your patient to is just so much bigger and higher. Then the other thing that we know, and we've seen that with the a couple of studies that was published, is the fact that when elective cases get admitted to hospital, in South Africa, almost 49% in the SASOS study was found to have anemia at the time of admission for elective surgery. However, if you speak to doctors in hospitals, they will tell you we don't cancel the elective surgery. We transfuse them and we take them to theatre tomorrow anyway. Otherwise, we're not going to get space to do the elective surgery anymore. So that is an unnecessary risk that you're exposing your patient to. It's unnecessary harm potentially to your patient, and therefore it's unethical. And if you look at the slides in the top right-hand corner, you will see the 3 pictures popping up time and time again, because what is on each slide is actually repeated in patient blood management principles. It's repeated in the ethical booklets of the HPCSA. It's repeated in the National Health Act and Regulation 179 of South Africa. So everybody is preaching the same story. Let's talk about justice. So justice is about the equitable distribution of benefits and burdens to individuals or social institutions. You must have fair, equitable, and appropriate treatment of all patients. So in transfusion, it means the following. Patients should be treated equitably for the same healthcare condition. So if apheresis platelets is available in Johannesburg, apheresis platelets must be available in Mthatha for a patient with the same condition. Medical decisions relating to transfusion should be based on best available evidence and the treatment options, adapted to your local circumstances. That is a very key point to keep in mind. Our patients unfortunately knows about Google, so they're going to go on Google and the whole family is going to start Googling options and treatment plans, and they're going to say, oh, but why don't you use a cell saver? Why don't you use this? Why don't you use fibrin glue? And the reality in South Africa is all of this is not available everywhere where we are. So it's very important that you talk to your patient in relation to what is available in your local circumstances. A patient should receive the most appropriate blood products available. And in a country where we are battling to get some of the specialized products, there might be times where you would actually want a single donor apheresis platelet, but there is no stock available in South Africa because 5-day shelf life makes it very difficult to keep platelets everywhere. In that case, your best appropriate product might be a filtered pooled platelet or a filtered pooled irradiated pooled platelet. So whatever is the most appropriate product available. Just in your notes, indicate how you came to the conclusion to settle for a specific product. Patients should only receive those products that are clinically appropriate and will afford optimal outcomes and optimal safety. Nothing more, nothing less, only what is needed. Wastage of a scarce resource may impact on the greater patient population. Many of you have received the letters to say, we are sitting at 2.3 days of stock level in South Africa. We are going to restrict the orders that you send in to us. Or got a call to say, doctor, you've asked for an apheresis platelet. There is no apheresis platelet available in this area or in this specific blood bank. Can I give you a filtered pooled? So please don't waste in one area because it may impact on a patient in another area. The whole thought about distributive justice, and this speaks to the fair, equitable, and appropriate distribution of healthcare resources. It also speaks of the allocation of scarce resources and the care of uninsured patients. And we know that there was quite a number of publications over the years about the inequities in the private and the public healthcare sector in South Africa. So I want to share some numbers with you just to think about. And the questions I'm going to ask, I'm not expecting answers to. I'm not sure that I even have the answers to them, to be honest, but I do think we need to ask them so that we as healthcare workers can think about them. So this is a publication that was a collaboration between SANBS and SACIMA, and they looked at the patterns of red cell product usage between 2014 and 2019. On the left-hand side is the public sector. On the right-hand side is the private sector. Now, of each graph on the right-hand side, the female group is on the right-hand side. If you look at the public sector female group and you look at the silhouette, that kind of makes you think of a pregnant lady. And if you look at the age group, and if you look at the data that we receive on our side in the blood service, that is women of childbearing age, that is the major users of red cells in the public sector. So my question is, if you go and you sit in these M&M meetings and you hear how the patient reaches the referral hospitals and the fact that they are so decompensated by that time, or that they come in there with an untreated anemia and just a normal amount of blood loss pushes them over the edge and they decompensated and now they clinically need a transfusion, you have to ask the question, is that silhouette that we're seeing there not actually speaking to the inequitable distribution of antenatal services in South Africa? Does it not speak to the fact that perhaps antenatal care and healthcare programs directed at women of childbearing age in South Africa in the public sector might be lacking? I'm asking the question. If you look at the private sector, you will see that we do not see that same picture in the female population. Same publication, a bit of stats. If you look at the two columns on the right-hand side of the screen, to the right, far right, is the per capita use in the private sector, and just to the left of that is the per capita use in the public sector. Now, the per capita use in the public sector is around 11 constantly. The per capita use in the private sector for 2014 to 2018 was in the high 30s, 38, 36, 37. I've just seen the stats on a publication that's going to come out for 2019 to 2021. And the per capita use in the public sector is now just over 12, but the per capita use in the private sector has actually jumped up to 42 almost. So you can only prescribe blood if there's a doctor to fill in the form, to make the decision that the blood must be given. A patient will only get a transfusion once they can access a level of health care where the type of treatment is provided, where a transfusion is needed for. So just looking at this, just these numbers should yell and scream at us to say, is everybody in South Africa given a chance to achieve their full health potential? So how is health equity in South Africa if the access to red cell products has got such a big discrepancy? Some more statistics of the 8 provinces in SANBS, and this is 2022 numbers. If you look at the red cell products used, public and private sector, you will see that in the public sector, on average 2.29 units of red cells are used per patient, and in the private sector, 4.02 units of red cells are used per patient. So again, the question, and you can debate that in the private sector you have got access to a much wider range of higher level of care, which often is linked to higher product usage. That is true. But it brings us back to the question, what happens to health equity? What happens to distributive justice if we are seeing pictures like this in our patient population? Looking at plasma products, we see exactly the same picture, 3.58 on average in the public sector, 5.9 in the private sector. And the same we see in platelets, 1.8 on average per patient in the public sector, 3.44 on average in the private sector. This is just per province, and the first bit I want you to look at is the average HB, and you can see two clear outlying provinces, 2019, 2021, and 2022. We didn't use 2020 because with the COVID pandemic, it just skewed all the data because the normal healthcare services was disrupted. And clearly there are two provinces in South Africa in the private sector, which is out of line on their average HB compared to others. Now, if you look at the bottom part of the graph, I deliberately made the average issues per request in purple because I don't think we should be looking at the average issues per request. It's not a fair comparison. Because if you think about the 83 blood banks in SANBS, the majority by far is in public sector hospitals. The minority of them are in private sector hospitals. So you cannot fairly compare average per request, because if I am away from a blood bank, I would be more likely to request 2 than 1, because I can't just run downstairs and get a backup unit. So I'm not looking at average issues per request. What I am looking at from a risk perspective to the patient is the average issues per patient. What is the amount of risk that I'm exposing my patient to? Because every product carries a full set of risks. Now, if you look at the private sector, the red, you can see right across the board, it's 3.8, 3.9, up until 4.5 even in some areas, per products per patient on average. While in the public sector, it's almost half of that. So that means in the private sector, just looking at red cell exposure, we are exposing our patients to almost double the risk than in the public sector. And you have to ask yourself, is it a justified risk or is it an unnecessary risk? Okay, let's talk law. Chapter 2 of the National Health Act. It speaks to all informed consent, not just transfusion. So it says the user must have full knowledge and the healthcare provider must inform the user. You require the consent of the user after you've given information. And that links to the ethical talk we just had. The patient must participate in the decision-making session. And that is patient blood management. Patient empowerment is part and parcel of patient blood management. There are considerations where you can give a health service without consent. And we also speak about our obligation to record keeping. It's a requirement of Chapter 2 of the Health Act. And this document to the right, which many in the room absolutely hates, we are well aware of it. And I know Western Capes look slightly different, but the information is still the same. That is a legal document. And the law stipulates that that clinical record of that patient must be kept up to a specific standard. So Chapter 2 also says what must your informed consent look like. It must be done by the treating doctor for a specified service in a language that the patient can understand at a level of the patient's understanding. It must be written and documented. You need a witness to consent. And if the patient refuses, also the whole process must be followed through and documented. What must you tell your patient? You must tell your patient what you're going to do, the nature of the treatment, the benefits versus the risks. And I love to, if I'm in the room with the doctors and the nurses, to say, please tell me what you think.
Dr. Wessels, I think we're losing you there. Let's just give it a couple of seconds to try and get Dr. Wessels back again.
I am back.
Okay.
I'm just going to share my screen again. That's why I was wary to have the video run, because the bandwidth is a problem. We tend
That's
to
fine.
lose.
You can leave the video off.
I've switched it off now. Can you see my screen?
Yes, it's on again. Thank you.
Perfect. Where did you lose me?
Not entirely sure.
Are we on track with this slide? Should I go further back?
No, I think that's the one.
You were on this slide, Doc.
You were on benefits versus risks.
You
Perfect.
were talking about
Perfect.
benefits versus risk, and we're saying
Okay.
when you see doctors and nurses, something you wanted to tell us something when you see doctors and nurses.
I was probably going to lie. That's why my video and everything cut out. Okay, sorry for that. We'll keep the video off, and then usually it's better with the bandwidth. So benefits versus risks. When I'm in the room with the doctors and the nurses, I love to have a discussion on what they think the risks are, because unfortunately we underestimate the risks of transfusion. Then you also have to tell your patient about the available alternatives, keeping in mind what is present and what is possible for your local circumstances. Please talk about the likelihood of success and watch how you word this. Be very specific what the planned outcome of the transfusion is so that you don't create false expectations in your patient. The number of interventions planned, the recuperation time, and the costs. Okay, so there are in circumstances in South African law where you can administer treatment without the patient's consent, and that is where the person has mandated somebody else to actually consent on their behalf. You can also seek consent from the spouse, the partner, the parent, the grandparent, the adult child, the brother, and the sister. And if you go and read chapter 2, interestingly enough, there's actually an order in which you should seek consent. And if you're from a very strict, traditional, Afrikaans-speaking farming community, to ask the partner that I've been living for 12 years and decided never to get married before I asked my father or my mother for permission, that can get you as a doctor into a bit of hot water. So just be very, very mindful of the sensitivity of the situation when you reach that stage. Treatment can also be authorized in terms of law or a court order. And if failure to treat poses a serious risk to public health, then of course you are allowed to administer treatment without consent. If delay in treatment may result in death or irreversible damage, you may intervene with emergency treatment. However, you must make sure that the user has not expressed, implied, or by conduct refused that service in the past when they were a competent adult. So Chapter 8 in Regulation 179 speaks more directly to transfusion. So the original Act read, only a registered medical practitioner or a dentist. And I was always worried about the dentist because, I mean, I'm sitting in the dentist chair and I'm wondering, what is he going to do that I'm going to start bleeding so badly that I actually end up needing a transfusion? Or a person acting under the supervision or instruction may administer blood. Let's do that section first. So we don't have how can I call it, the privilege in South Africa where a doctor is standing next to the bed every time a transfusion happens. So supervision is out of the question in our setting. So best we give an instruction then, otherwise we are in breach of the law. And that instruction is your prescription to the nursing staff on how to do the transfusion. What is the rate? If there's multiple products, the order of the products that must be transfused. So that is your instruction. Now we move to prescribing blood and blood products. So we do have many instances in South Africa where we find that the blood is prescribed telephonically and the nurses are completing the request forms. I would just like to make everybody aware of Regulation 179, and I urge you to go back to your hospital settings and make sure that your process that you are following is actually compliant to Regulation 179. That was published in 2012, where it says no blood or blood product may be ordered unless it's prescribed by a medical practitioner in writing on a form created by the Blood Transfusion Service. Keeping in mind that those of the colleagues who is in the Netcare setting, we are busy implementing electronic ordering. We're rolling out through the country. That form on our side, that with the content that you see on your side, when we created it from our side, it was still created by the blood service. So that is still a legal request form. Regulation 179 also spoke to the participation in hemovigilance for anybody undertaking any activity in any part of the transfusion chain. Now, hemovigilance encompasses all adverse events, but it also encompasses all lookbacks. Now, in order, like I've said earlier, a look back is where my donor come to donate. We do all the testing. The tests are negative. The unit is released to a blood bank. A patient gets the unit. The donor comes back to donate after 8 weeks. We run all the tests, and now we pick up a marker. And it's usually a hepatitis B because the window period is a bit longer. They tend to hide longer. And now we inform the doctor to say, Doc, on this and this and this date, on our system, you were the ordering doctor of this unit to this patient, and it might be possibly a window period donation. And then you have to inform your patient. Remember that ethical principle of informing them post-transfusion if anything comes to the light. You have now to bring them back, counsel them, test them, and see if there was any transfusion-transmitted infection that took place. However, we can only do this for our patients and provide our patients with this service if we can link the unit to the patient. If the record keeping is of such a nature that we cannot link the unit to the patient, it means that we are depriving the patient of that support service. So this is the request form, and I know Western Cape's looks slightly different, but the content is actually the same across the board. So let's talk about the patient information. You have to keep in mind, I need to link the unit to the patient to be legally compliant and to ethically be able to inform the patient of any information I may be informed about post-transfusion. So Mukwena, K-O-E-N, and Mukwena, K-W-E-N, are two different files on Meditech. So therefore, the way you fill in the patient information is actually crucially important. We pick up sample switches in the blood banks at least once a week in South Africa. And the reason why we pick up the sample switch is because last week this patient was an A. And the sample comes in today and it groups as a B, and immediately we know there was a sample switch. But if I cannot link last week's patient to this week's request because the patient details were given to me in different formats, then I am depriving the patient of that additional safety net. Now, your choice of product, remember, the best product available, most appropriate product available, keeping cost in mind, keeping scarcity in mind, knowing the clinical indications for each type of specialized product, sticking to the least products required for this specific condition. All of those hold legal and ethical implications. Your choice of pre-transfusion testing. Now, I am going to share with you some information that we get from nurses once the doctors and the managers leaves the room across 8 provinces. If the nurse fills this form on behalf of the doctor, I sat in trainings with 5 hospitals in 1 week, where the nurses told me that unless they tick the block emergency, then the courier driver is not phoned to come and collect the samples. So doctors, you may think your patient is getting a standard full cross match. Make very sure what the process in your hospital is, that emergency block is not ticked on your behalf, because ultimately you as the doctor is responsible for exposing the patient to the risks and the benefits of this transfusion. Because when you tick emergency cross-match, you are opting for a partial cross-match. To put it in layman's terms, you are opting for the room temperature testing. It's not incubated and the testing at 37 degrees has not been concluded. Your patient's body temperature is not room temperature, it's 37 degrees. I think you are understanding the whole implication of ticking that emergency box on the request form. You've heard ethically, legally, patient blood management principle, there must be a clinical indication. So therefore the diagnosis is very important. So we get multiple forms with a single word, anemia or D64.9. So if something goes wrong, how are you going to justify that anemia or D64.9, just that one word and those few letters, are adequate diagnosis to expose your patient to the risk of a transfusion? And we've had multiple requests for blood request forms because the patient files got lost and the only document standing was this form which the blood services keep forever and ever. Then the treating doctor, please, there must be a contact number. If we pick up any irregularities, then we must be able to phone you and say, Doc, there's going to be a delay in treatment. Because if I can't get hold of you, I cannot release the blood. And that means the fact that I couldn't get hold of you is actually the reason why treatment to the patient is delayed. And I mean, that is both ethical and legal implications right there. Then that beautiful pink-red block that nobody ever reads. And we say it's warning. We have big fat red letters. We put it in pink and doctors never read it. The warning states that you know blood can transmit diseases. It states that you know how it's collected, you know how it's tested, and you know what it is tested for. It also states that you are aware as the doctor exposing the patient to the risk of the transfusion. There is always a risk of a window period donation and therefore transmitting infection, although the test was negative. It also says that you as the doctor exposing the patient to this risk have discussed all of this with the patient. You've got an informed consent. You know that it's medically justifiable and you have considered all your alternatives. Now, if you just follow the instructions or the warnings that we put in this block, you will tick the ethics block, you will tick patient blood management blocks, and you will tick the legal block in South Africa. This is the form that is linked to the uncross-matched blood in the emergency fridges. So first of all, it's a whole different level of risk to your patient. Is it truly a life-threatening emergency that you must expose your patient to uncross-matched blood? Again, who sealed these units into the fridge? Because you know when we speak red cells, cold chain is the key thing here for safety and quality. Who sealed it in the fridge? Who took the temperature of this unit? Did you check that the temperature was documented there? If you don't know what the cold chain maintenance of the unit was, how do you expose your patient to this unit and saying, oh, I've done my duty, I haven't exposed my patient to harm? Again, we must be able to link this unit to a specific patient. And when we speak about O negative and O positive units in the emergency fridge, we cannot just give all patients O negative blood. The O negative blood must be preserved for O negative patients, especially of childbearing age. Therefore, you have the duty to perform an RH test on the patient to make sure that the principle of distributive justice is applied. You must make sure it's a life-threatening emergency, otherwise you cannot legally or ethically justify using uncross-matched blood. You have to say who is the doctor who made the decision to expose the patient to uncross-matched blood. And if there are junior doctors in the room, I know what happens. You are coming on duty the next morning and the nurse runs up to you and say, the doctor didn't fill the form yesterday and now the blood bank won't give me a replacement unit. Doc, please just sign the form. Doc, if you sign the form, you said you are the doctor who made the decision to expose the patient to uncross-matched blood. Don't sign forms if you were not the doctor who made this decision. Litigation is unfortunately a reality in South Africa, whether we want to acknowledge it or not. This is from various websites. If you go and you just type into your browser transfusion litigation in South Africa, you're going to find several of these sites popping up. And this one specifically talks about faulty blood transfusions. And it says that you have the right to look at your own medical records. It teaches the patients that you can look at your own medical records, that's your right, and those records will help you to build a solid case if you want to litigate. It also, this is from another site, where it teaches the patient to say what constitutes medical malpractice, and it says where the practitioner failed to obtain consent, the practitioner didn't adequately explain the risks, where an administrative error or improper testing led to the wrong blood type being transfused. We had a terrible, terrible, terrible case of misdirected transfusions just week before last. It's really, I obviously can't go into details, but that was clearly an administrative error on the side of the hospital, where a blood transfusion was given when it wasn't necessary. Please, I'm going to repeat that one. Medical malpractice constitutes cases where a blood transfusion was given when it wasn't necessary. Where a blood transfusion was administered improperly. I'm thinking about all the weird and wonderful ways our nursing college still believes to warm the blood, popping it in bed with the patient, popping it in buckets of warm water in theatre, etc., or where infected blood was transfused due to improper screening. They also say that personal injury claims can be made against the medical practitioner who performed or ordered the blood transfusion, the hospital where the infusion was administered, or the blood donation service that supplied the blood. So whether we want to know this or not, litigation is a reality in South Africa, and unfortunately transfusion is a very easy target. A little bit about intellectual liability. This is where harm or damage was caused, either negligently or intentionally. So negligence is deemed to be present if a reasonable person would have foreseen harm and would have taken steps to avoid the harm, but the defendant failed to take such steps. In the case of experts and professionals like the people on this call, your conduct will be measured against the conduct of a reasonable expert or professional. So generally, it's considered that it's difficult to prove that the transfusion service or the doctor was negligent if they adhere to legislation, the law, regulations, and standards of practice applicable at the time of transfusion. Standards of practice in today's medical environment include patient blood management principles. We cannot get away from that. Criminal liability. There are two things that can happen here. You can be found guilty of assault. That's when you're administering a transfusion without the necessary consent. Or culpable homicide, where wrongfully or negligently the death of a person was caused. So there might be negligence either by a blood service, a practitioner, a hospital, whatever the case may be. The patient demises, and the individuals involved may be charged and convicted of culpable homicide. Practitioners who order blood must be aware of their legal responsibilities. And then there were two cases in South Africa in history thus far where people were found guilty of culpable homicide. It was an unrelated cases. One was where a medical practitioner was found guilty, and the other one was where a blood transfusion medical laboratory technician was found guilty of culpable homicide. So I have tried to group things for you a little bit to sort of group your thought patterns around the responsibilities of the practitioner who orders and transfuses blood in South Africa. You only transfuse blood when it's clearly medically indicated. You have to warn the patient of the potential risks inherent to transfusion and inform them of the available alternatives. And you have to document and obtain informed consent. So those three happens before you have even touched the request form. So long before you even request the blood, there are certain legal responsibilities. Now, the next group, I want you to ask yourself, how am I going to do that if I'm not in the ward? Because you need to ask this from yourself. Correctly identify the patient and the units to be transfused. Ensure that appropriate compatibility testing have been performed. Have they ticked standard cross-match or have they ticked emergency cross-match? Ensure that blood has been correctly handled prior to and during the transfusion. Ensure that the blood has not passed its expiration date, and only permitting responsible persons to administer blood to the patient. So you are not standing in the ward. We've already established that blood transfusion does not happen under supervision of the doctor. Therefore, it must happen under instruction of the doctor. So the way you can make sure that you can tick those boxes is to immediately, when you get back to work tomorrow, ask for all your hospital transfusion policies around transfusion of blood products, so that you can check whether your current policies in your environment actually addresses each one of those points adequately. And if you feel it's not adequately addressed, then you must speak up. And then when you prescribe a transfusion, you can say, okay, I want to make sure the rate is proper. So you're going to transfuse the red cells 2 to 4 hours, or you're going to first transfuse the platelets and then the red cells. And then to cover those bracketed block on the top, you can say, please follow hospital protocol to administer the blood product. So then you must make sure your hospital protocol talks about patient identification, where the products waiting to be transfused are being stored, how the checks, ID checks are being done, how the checks for the quality and the viability of the unit is done, and if the people doing the transfusion has actually been trained on the policy. Now, the last group is again very much like the first bracketed group. You are not there at the bedside observing the patient throughout the 4-hour transfusion. But one of your legal responsibilities is to make sure that observation and monitoring of the patient before, during, and after the transfusion is done correctly, that a transfusion reaction is noticed, reported, and acted upon swiftly, that the blood samples is required and is retained as required post-transfusion, and that all reactions and deaths are reported. So doctors, I urge you to have a look at your hospital transfusion policy and make sure that all these boxes are ticked. Because if you can tick all these boxes, and you can add that you make sure you trace, counsel, and test recipients that you are identifying through the look-back program, I promise you, you will have optimal patient outcomes. So in conclusion, we must please empower our patients with adequate and appropriate information and allow our patients to participate in our decision-making process. We must also always consider the 4 ethical principles, and we must not limit our patients' options because our knowledge might be outdated. We must show cognizance of our legal obligations, and you must know your legal responsibilities regarding transfusion. Always apply patient blood management measures and always screen for and treat anemia. Thank you very much. I'm going to stop sharing.
Thank you, Dr. Wessels.
And we can have some questions.
I'm going to hand it over to Dr. Mzukwa, the CEO of SANBS, the chairperson of SANBS, and he's going to take care of the Q&A session for you. And handing over to Dr. Mzukwa now.
Thank you so much, Dr. Wessels, for this informative session. I would like now to ask to go through the questions. I'm sure colleagues, I see questions, many of these have been posted. The first one says, please go through the risks of transfusion that you discuss with the patient. I think it was under patient consent.
Yes. So we tend to think about transfusion adverse events, and we tend to think about transfusion-transmitted infections. But we forget about the bigger risk. You know, the patient blood management literature that was published speaks to a dose-dependent negative outcome when you transfuse red cells. There's been publications that says once you go over 3 units of red cells, your post-cesarean infection rate quadruples. There's a lot of literature that speaks about the negative outcomes of red cell transfusions. There's a lot of literature that shows you that by applying patient blood management, you can reduce thrombotic effects like stroke, myocardial infarct. You can reduce length of hospital stay, ICU admissions, post-op infections. So all of those are actually risks of transfusions. We also have to think about the scarce resource in South Africa and how we struggle to have blood products available everywhere across 8 provinces. And I don't doubt that Greg and Catherine has the same problem in the Western Cape. And you have to ask yourself that the risk is, if I waste here, I'm putting another patient, maybe in Lusikisiki or Springbok or wherever, at risk for not having a life-saving product. So the risk is much broader than TTIs and adverse events. Thank you.
Oh, thank you so much, Dr. Wessels, for that. I think let's go to the next one. It says, an elderly middle-income patient is converted to retropositive, positively diagnosed after seeking medical help after recurrent episodes of oral thrush. A history of a 6-month previous blood transfusion was noted during an elective surgical procedure. Can transfused blood transmit HIV?
Okay. So I think the first thing that I'm worried about in that sentence is the elective surgical procedure. Why did we not treat the anemia properly before the patient was admitted for the elective surgery? Now the patient is admitted for elective surgery and we submitting him to a red cell transfusion. So just keep in mind that that's a whole additional layer of debate around this case. But yes, to answer the question, in South Africa, we test for HIV, hepatitis B, hepatitis C, and syphilis. And yes, HIV can transmit, but remember, we are doing individual NAT testing, nucleic acid amplification testing in South Africa. We're not doing mini pools because we are aware of our burden of disease. We are doing individual NAT testing, and we double up with serological testing. So it is possible, but and I think I've heard Caroline's voice on the webinar, and she helps to compile the annual hemovigilance report for South Africa. I think in South Africa we are only aware of 2 HIV transmissions throughout after we have started implementing NAT testing in South Africa. Okay.
Thank you very much. The next one is how long is a cross-match specimen valid for? Also for type and strain.
So a cross-match specimen is valid for 72 hours. So once you send it to us, we can keep it for 72 hours because you might phone us and ask for a top-up unit to be issued, and we can use the same sample. But remember that if we want a very good result, we need to, and I see he's talking about a week or 2 afterwards and needs more transfusion. You have to send a new specimen, because that patient has been exposed to foreign red cells now. And we have to double check that there is not irregular antibodies that's now coming up on the screens. So that is for that week or 2 afterwards, you do need a new sample. Okay.
Okay, and how long is BRB blood valid for? When and which can be returned?
So let's first explain to everybody on the call what is BRB. It's blood on returnable basis. So as a general statement, once the blood has left our oversight and it's not in our custody anymore, we cannot vouch for the cold chain. So therefore, we cannot take it back and expose a next patient to the potential risk, because we don't know what happened to that blood when it wasn't with us, unless It is on a blood on returnable basis hamper. These hampers have been tested and validated for 12 hours. And if we receive them back in 12 hours, and the seals have not been broken, so we know the unit cannot be tampered with, and it's within the temperature range, then we can legally and safely put that unit back into the inventory and give it to a next patient.
Thank you. And is the diploma in transfusion done at the University of Free State only?
Unfortunately, you're looking at the last year group that had the privilege of doing that diploma. After 2013, it wasn't offered anymore. However, yesterday we launched the PBM short course with the University of the Free State. That's a collaboration between SANBS and the University of the Free State. Fully online, 14-week course. And our first group of doctors, we're extremely proud to say, have started yesterday. So we plan to have 2 intakes per year. So the doctors is up and running, and early next year, then the nurses stream will launch, and a little bit later in the year, the laboratory professional stream will also launch.
All right, and I think we've already answered that question. In apart from hepatitis B, what other infections can be transmitted in blood transfusion? Any risk of HIV? I think you did allude to that.
Yeah, but just keep in mind there's something called emerging pathogens. Remember when, what was it, the Olympic Games that was in Brazil? There was a big sporting event in Brazil, just as there was a Zika outbreak in the world. Zika was a blood-borne pathogen, hey? You might not realize it, but in the world of transfusion, it was a frenzy, making sure that should something happen, the rest of the world can get enough blood to Brazil. Because you never know which is the next blood-borne pathogen that pops up. And therefore, emerging pathogens must always be in the back of your mind.
All right, thank you. I would like to please ask who covers the cost of the testing of the patient in private post-transfusion when there is a situation of a window period donation?
So the doctor, the person, so let me start at the beginning. So when you have an informed consent discussion with the patient, you need to discuss the possibility of window period donations, and you need to alert them to the availability of the Look Back program. So we've had patients that could not afford to do the testing. They might be in private, but they don't have medical aids, and I know SANBS have assisted with those testings in the past. But in the public sector, it's covered by the public sector. However, let's say the patient tests positive. You do your basic serological test that you do in the hospital. You get a positive hepatitis B or HIV. So now you have to move to phylogenetic testing, which is obviously more expensive, and then SANBS actually pays for the phylogenetic testing.
Thank you. In patients who are Jehovah's Witnesses and have a severe anemia, say 3.5 so, and are admitted with an acute delirium or acute confusional state with features of cardiac failure, if a medical professional is unable to reach the family to obtain consent, would the doctor be able to transfuse this patient with permission from the medical superintendent of the hospital? What could one do?
So I think my question is, are you aware to Jehovah's Witness? If the answer is yes, if you can see any previous decision of the patient that they don't want to be exposed to blood transfusions, you are not allowed to override their wishes in an emergency situation. Eh? So if you can see any directive that the patient refuses a form of treatment, please don't think you can override it. That decision was made by a competent adult. That was his or her choice, and we don't have the right to override that.
Thank you. How often is an infection transmitted to a patient via transfusion?
So I'm aware, I've been with the blood services for 12 years. NAT testing was implemented in South Africa in 2005. We issue between 1 and 1.2 million products per year in South Africa. I'm aware of 2 HIV transmissions and 3 hepatitis B transmissions. That's all I'm aware of. Since 2005, it's almost 20 years, so you can say it's 20 million products. I think you can do the maths.
Okay. Just I lost my. Okay. Please advise on the extent to which blood should be warmed before transfusion, and how best warm it in the absence of specific blood warming equipment.
Okay, so the first thing is that 95% of your patients can get their blood cold. There is 5 clinical conditions where you need warm blood, and nobody else needs warm blood. Blood can only be warmed by a validated blood warmer that has got an audible alarm. You must distinguish between a slow rate warmer and a high flow rate warmer, because otherwise you're either going to be transfusing cold blood in a trauma setting if it's a slow flow rate warmer, or you're going to be transfusing hemolyzed blood to a medical patient or a neonate if it's a high rate high flow rate blood warmer, but you're doing a slow rate transfusion. So all blood warmers is not created equal, né? And then I would advise everybody they can pop onto either the Western Cape or the SANBS blood transfusion services websites. The clinical guidelines are posted there, and it will give you all the indications for warming blood, who needs filtered red cells, who needs irradiated products. So all of that specific patients groups are in the clinical guidelines, and you can download it free of charge.
Okay, thank you very much. How to deal with a witness, Jehovah's Witness, refusing blood transfusion for the 5-year-old boy with severe anemia?
Okay, so keep in mind that the whole thinking about this is that at the age of 5, the child is not emotionally mature enough to make a decision around the acceptance of a specific religion or faith that might deprive him of a certain treatment option. You also have to keep in mind that in South Africa, all children, the state is their legal guardians. So you are allowed to follow the legal process in your specific hospital. And I always advise doctors, make sure you know how that process works, so that 3 o'clock in the morning when you need to the process, that's not when you try to find out how it works. There is a process for each hospital on how to get permission and override the parents' wishes. However, and I don't even want to breathe before I say the however, the moment we go that route, as doctors, we must understand that our patients also, it's not just physical health that we need to have to look after. You have to look after the social structure, the mental and emotional health and well-being of the patient and of the family. So a decision like that can be disruptive to a family and may be seen by the family as being very one-sided and, disregarding their beliefs and wishes. So I would advise that you get the social worker in on this case, get support for the family, and just help them through this, because they're not refusing because they don't want to help their child. It's a true, firm, very deep-seated religious belief, and we need to help them through this very difficult situation that has now come up.
Thank you very much. Do you advise HIV testing before transfusing a patient?
No, I wouldn't advise that. I don't think I've come across any hospital policy that advise HIV testing before transfusing. I do know several hospitals prefer to do HIV testing before surgical procedures. That is a quite common practice that I've come across.
Okay, thank you. Whose responsibility, either as SANBS or clinician, is to pay for costs incurred to bring a patient back for testing under the look-back program?
So I think we've answered that, but I'm happy to revisit. So in the public sector, I know it works through the normal system, how a patient accesses services by, if I can't test in the local area where you are, you come with the transporter to a bigger hospital and the blood is drawn and it's tested. In the private sector, it comes back to when you do your informed consent, you must tell the patient of the possibility of window period donations, and you must tell the patient of the available service of a look back program. So then your patient will actually know. It won't be an unexpected call. It's not the first time they hear, come back and come for a test. Like I've said, once we've got a positive test on that preliminary test, the phylogenetic testing must ensue, much more expensive, and that is when the blood service foots the bill.
Thank you
That is
very
also
much.
not, sorry, the phylogenetic testing is also not done by the blood service. That is done by an independent external lab.
Okay. Thank you so much, Dr. Vessel. I think you've covered all the questions. The last two questions you've already attended to in your responses. I think let me just thank you very much, Dr. Vessels, for a truly informative session. You've enriched the webinar with your invaluable insight and experiences. You know, patient blood management is not just a concept, but a philosophy that places the patient's well-being at the forefront of medical practice. By prioritizing individualized care, we minimize risks, preserve resources, and contribute to the overall advancement of healthcare. Let us remain committed to staying updated with the latest research and advancements in this field. Continuous learning and the pursuit of excellence will enable us to further refine our practices and make significant strides in patient care. Colleagues, as we have come to the close of this discussion on patient blood management and return to our respective roles in the medical community, let us carry the torch of knowledge and enlightenment with us. Let us continue to advocate for the adoption of PBM principles in our institutions, sharing the benefits and success stories with our colleagues and peers. With those few words, I bid you a good evening. Thank you very much. Have a good night.